Hi, welcome to Shrink Sharing. I am Dr. Wilona. I am a psychiatrist practicing in Mumbai, India.
Hello, I'm Dr. Ruksheda. I'm a psychiatrist and I'm based here in Mumbai, India, just like Dr. Wilona.
So, Ruksheda, when we talk about mental health, and given that with this entire increase in the number of people reaching out for mental illness and mental health concerns, I'm sure you have your fair share of patients who come to you for the first time and have no clue about what a mental illness is all about. So, what do you do with these patients? How do you explain to them the concept of a mental illness?
So first of all, so much more happier that people are reaching out and coming to us. Like, we should all give ourselves a little pat on the back because we've worked really hard to improve on the awareness and all of that. So good job, yay. Now that people are reaching out to us various ways, right? Whether they're coming to us in one-on-one clinical aspects, or they're reaching out to us via other avenues, or DMing us in the middle of the night, because that happens. How I go about saying this is that there's mental health illnesses, and then there are mental health disorders. So just like mental health, just like physical health, what we need to do, like routine and good nutrition and healthy routine or daily basis, a good lifestyle, that's the same thing that we need to do for mental health as well, because they're not different. The brain is part of our body, and the brain is actually the epicenter of the body, isn't it? Because it controls all our functions. So the way I describe a disorder to them is I first start with saying that this is a medical disorder, because a lot of people still don't kind of recognize this as a medical disorder. They'll come up to me and say that, oh, because I'm stressed about something, that's why I have this illness. Or because, oh, I've always been like oversensitive, or I think a lot, or because this has been going on in my life, that's why I have an illness. So I start with that this is a medical illness. We have to start understanding it from a biological perspective. Otherwise, we're always going to get that stigma that comes from ignorance, and it comes from shame, isn't it? It's not a curse. It's not a sin that you may have committed in the past, and that's why now you're suffering from it. So just like any other medical condition, like blood pressure or diabetes or thyroid or liver diseases or even cancer for that matter, mental health disorders are genetic disorders. That means it may be inherited genetics. I may have more of a risk of a psychiatric disorder if there is genetic illnesses of other psychiatric disorders like schizophrenia or bipolar or OCD or depression or anxiety in my family. Or it could be my own genetics. These are my genetics. So I'm more vulnerable to having a psychiatric illness because it's an illness of the brain. It's a neuropsychiatric illness, it's a neurochemical illness, it's a neuroelectric illness. It impacts our brain, and that's why it impacts other functionings of the brain as well. But the predominant thing that we do notice is mood changes and behavior changes and thought pattern changes, which of course impacts our action. Not to say that we don't have physical impacts of a psychiatric illness as well, but now just because we're kind of like, this is how we talk about it, this is how I explain to people. So the way I found that it's always very nice to talk about is like, I'm like, okay, this is a room that we are sitting in, right? So this room has walls. So that means it has a structure. This room has paint and waterproofing. That means it has chemistry, the chemicals in it. And it also has wiring for lights and AC and fan. That means it has electricity. So for this room to be completely functional, we need all of these things to work together. Now, for one reason or the other, let's say there's a tornado going through this room, or let's say there's a small drip of water that kind of, from a leaked pipe that is kind of, continuously dripping on a daily basis. So it will kind of, disrupt the chemistry of the walls, like the paint will peel off, the waterproofing will peel off, then it'll reach the wires and there'll be faulty wiring and short circuit. And then eventually maybe the walls will also kind of start either crumbling or falling or becoming weak. So just like that, when you have mental illness, this is what happens to your brain. We can show it to you on MRI scans. We can do a lot of, of course, these MRI scans are very expensive, so we don't do it for every person. But there's definitely that we have the evidence that your brain when you're normal looks different, and your brain when you have an illness looks different. And a brain with schizophrenia will be different, and a brain with depression will be different. So different parts of your brain are going to get impacted. So when I explain this in this manner, a lot of people kind of tend to understand what we are saying. Because unless and until we do that, and and we tell them how it is very similar to another illness, and how just like other illness, like it requires a trigger. Mental illness also may require a trigger. They may require a trigger. It doesn't mean that there always has to be a trigger. And the trigger can be without us, like in my environment, like I said, maybe a tornado goes through my life, or like a small drip of chronic stress that's leaking into my brain. Or it could be an internal environment, like maybe I have a hypothyroid disorder, or maybe I have Parkinson's, or maybe I'm taking some medications that is impacting my mental health. Like even anti-tuberculous medicines can cause a lot of psychotic symptoms. So these environmental triggers could be a reason for me to have a beginning of a psychiatric illness. It doesn't mean that that is a reason. A trigger is a trigger. It's not a reason. So if I had a huge traumatic life event in my life, and that may have triggered my, let's say, depression or PTSD or anxiety, doesn't mean that that is the reason for my depression. Because then if I say that, then that means that, oh, I wasn't strong enough, I wasn't resilient enough to withstand that stress, and that's why I have an illness. So there's a lot of self-blame in that, which is definitely not what psychiatric illnesses are. And this is very important for us to understand, for us to share with other people. Like I said, like you said, that a lot of people are coming out to us, and we need to normalize this talk. We need to normalize this understanding of what really happens. They don't necessarily have to know which circuits and which neurotransmitters, but if they do know, that's wonderful. So, these are some things that I say, and a lot of my sessions kind of go through this. And trust me, sometimes I have to keep repeating it, and, multiple sessions as well, because sometimes it takes a while for us to kind of, prick at the years of misinformation that kind of overshadows our understanding of mental health and illness. But it's very, very important that we talk in very lucid terms, and we talk in a very relatable term as well, so that this aura and this mystery around mental health and the shame around your mental health also kind of disappears. What do you think? Do you think it makes sense? Do you think what do you do differently?
So I absolutely agree with you when it comes to the way you've explained mental illness to patients. I really like that you brought the biological aspect into it, because a lot of times they tend to blame it on a lot of things that are not biological. And unfortunately, this is also part of how they look at psychiatry. Like, it's not biological, it's in your mind, but that doesn't mean it's in your brain, physically in your brain. And they don't understand that it is something that is actually a medical issue that could be sorted out with treatment, with the adequate, appropriate treatment for the right duration of time. So I think I use most of the things that you say. I really like the analogy of the room, and that makes it a lot more easier to convey to patients. One thing that
Well,
struck
you can
me
use it
from...
next time. I don't mind sharing the copyright.
Absolutely, I am going to definitely use that with a few patients. One thing that strikes me, and which I want to add to what you've said, is that is something that one of my teachers taught me. He said that when our mind is in balance with our body, there is a perfect equilibrium between our thought, between our emotion, and our behavior. And in times of distress, there is definitely a stretch on either of these, which causes, say, disturbances in thought. Like, we could have too many thoughts running in our head, or too little thoughts running in our head, or we could have a lot of energy or too little energy. And when there is a complete disruption of the entire system that balances our mental health, that actually causes the stretch on each of these systems to pull so hard that things break. And that is what he defined as a mental disorder, which I use sometimes to explain to my patients. So they understand the concept of stretch and strain, which means that they need to seek help, and the break or fracture, which means that they need to get medication. That makes it a little easier for me to talk to my patients sometimes.
Wonderful. I these examples and the metaphors, or the simplistic language that we use, translates that medical jargon into understandable terms, but still keeps to the science of it, still keeps to the essence of the science. And I think because we look at science, especially psychiatry, as a science and an art, everybody just looks at the art, and people tend to forget there's this huge science behind it. And that's why I think there's so much more hesitation in terms of talking about mental health and talking about mental illnesses. So I think it's important for us to kind of keep having this conversation and similar conversations. And I hope that, like I said, we bring it to a lot of more living room conversations and normalize it to that extent. Now that I have you here, and we did, start talking about illness, and I started talking about science and art, another thing that keeps coming up, right, that when I have a patient, the one of the first things that they'll tell me is that, you know what, I understand I have an illness and I need help, but I don't want medications. And if mental illnesses have like a stigma and understanding of it, oh my God, the stigma behind medications and the misinformation about the medications is next level. So I'm sure, you are such a experienced psychiatrist, and you see so many patients on a daily basis. I'm sure you get the same kind of question. It's by now the explanations are almost like you switch on like the tape and it goes on. So what is it that how is it that you explain to them, okay, what is medications, or how are they important, and what should you look for, and what should you watch out for?
That's such a perfect question today, because I had a first time diagnosed patient with bipolar disorder today, and I spent the better part of my morning trying to explain to her why medications are needed, why the medications will help, and how they will help. So that took me, I think, almost about half an hour or 40 minutes of discussion with her. So typically how I start is I go into the biology of the illness. Like I try and explain to the patient what they have based on the symptoms that they have reported. So based on the symptoms that they've reported, if I feel that they have a particular disorder, I tell them, this is what I think you have, and these are the reasons why I think you have this. And then I move on to discuss with them the possible treatment strategies that we have. So very often when patients come to us with a medical disorder, a medical psychiatric disorder, uh, the first line of treatment is medications if the disorder is significantly severe enough. So if there is enough of symptoms to warrant the use of medications, I explain to them. You know, and I know that very often patients only reach out when things are at a severe stage and not at a mild stage. So more often than not, I have to have this conversation with patients where I'm telling them that, the meds are needed and you will need to consider taking medications. I think it really helps them when they understand that it is biological. They are also able to accept the fact that there are definite changes in their thought process, in their behavior, in their emotions, which need to be modified. So if we offer medications as one way of modifying them, sometimes it is easier for them to accept, because by the time they've come to us, they've already tried, talking themselves into calming down, talking to relatives, talking to friends, sort of seeking help from all the first aid kind of sources in mental health, and none of that has worked. So that's why they've come in front of me, and they're sitting in front of me for treatment. Once I've explained to them the biology and why the meds are needed, I also take some time to talk to them about their concerns. So some of the concerns that come up are, I really didn't think that it was so bad. And I get that. Honestly, I do. Because a lot of times patients don't even know that a symptom is a symptom. For example, so many patients reach out with depression, but they don't even know that lack of energy is one of the core symptoms of depression. They think, I'm tired, I'm just doing too much, I'm overworking myself, or there's too much pressure on me. They don't realize that it is one of the symptoms that we look at to diagnose a clinical depression. So I explain to them with the reference of what symptoms we use for diagnosis, so that they're able to understand why I'm saying that this is depression. It also helps because when they go back and Google, they can see that what I was saying was actually, what made sense. And so then their trust is also, is reinforced sort of in the process. Some of the concerns that patients often have with medications are that I don't want to become a zombie. These meds are going to get me all sleepy. I've had a relative who was on psychiatric medicines and he was always sleeping all the time. So while I understand that some meds do have insomnia as a side effect, and I also understand that quite a few patients reach out to us with sleep deprivation as a common concern. So we have to use medications that cause some amount of drowsiness. But I think we have a number of medicines in our, in our basket of choices that we can offer to the patient when we think about what could work well for them, especially if they are insistent that sleep is not something that they want to work on. So that is something I always discuss with my patients. If sleep seems to be disturbed, I talk to them about the possibility about starting a medicine that might cause some drowsiness, but later on switching to something that can be used effectively in the day as well without any sedation. Most of them seem to be okay with that. If, of course, there is too much drowsiness, they can always come back and reach out and modify the dosage of the medication. It also helps when I start with smaller doses, because on the smallest dose, if they're very drowsy, then then they're lesser confident to increase the dose, and then we can just change the medication to something else. Another common concern is, will I get addicted to the medicines? Like, I don't want to get hooked onto the medicines. And this is a serious concern, especially with the labels that psychiatric medicines have attached to them. So I often tell my patients that medications and the entire therapeutic process with uh, pharmacological agents is necessarily a give and take relationship between us. So we have to see what works, we have to see how much it works, and once it works, we have to continue it for an adequate amount of time to make sure that the patient gets the benefit, the full benefit of the medication. Usually, when patients have continued it in that order, they haven't really faced any difficulty getting off the medication. Of course, there are those cases like when a patient of long-standing schizophrenia comes, or a patient of bipolar disorder comes, and we have to talk to the patient at the first visit itself and explain to them that possibly lifelong medications is the only way. But I've found that they're far more receptive when they understand that we could make it a choice to keep the medications as realistically minimal as possible and as free from side effects as possible for them. So this is again a give and take between me and the patient, and both of us discuss which is the best combination of medicines to work with them.
Right.
Another
So I
common
think so I think what that point is like really important, that a patient works with the psychiatrist to come up with a treatment plan, and it's
Absolutely.
not just something that a psychiatrist is just going to decree, and you have to follow it. So I think that's very important. And then the other like really important message that you were saying is that information is key. If more people understand what medications they've been given for and why, then they're more able to accept it, not only in terms of that they need the medication, but also the fear that is attached with the side effects of the medications is much less. So that those are really important points, I think, that all of us need to be concerned about. But of course, there are also times where like especially if you are in a busy work setup where not every patient has the access to a longer session. Some of our patients are in rural backgrounds and smaller cities and towns where a doctor is very busy, unfortunately, because the workload is so much. So how do you think that, in a short period, in a quick period of time, that we can explain to them and still reassure them and give them authentic advice, at the same time, work with them in terms of allaying their fears as far as medications is concerned?
So I feel that we need to be as briefly clear as possible, because we'll need to make sure that the time frame that we have with them. For example, some of the OPDs that I go to are charitable OPDs where there is a heavy flow of patients, and still I feel it is important that the patient should understand what I'm prescribing and why I'm prescribing it. So I've been able to manage that even in a short duration of time. Of course, they don't get as much content as I would give a patient who, say, I'm spending 40 minutes with. But even within 5 to 10 minutes, I've been able to at least explain to them the basic expected side effects, what they should watch out for, what's okay, what's not okay, in a very short and clear manner, so that they're able to, be reassured if there is any problem. Of course, videos like this are going to help. So we should try and put out more of these, because I think the more people understand that there is, of course, with every medication, there is a pro and a con, and we're giving the medication because we definitely want the pro to happen, right? We want the mood to improve, we want the mood swings to stop, we want the anger to reduce, or we want the negative thoughts to stop. So we're giving it for a particular reason, and if there is a con attached to it, we need to weigh that con and see whether it is heavier than the pro or whether it is lighter. If it is heavier, yes, by all means, let's discuss and let's change the medicine. But if it's lighter, then
Because
let's look
right.
at,
So
working with it.
I completely agree that we have to come up with like that cost benefit analysis in this term as well. And I think one very important point also that you were trying to highlight is that these medications are life saving. I mean, somebody with negative thoughts and suicidality, we could actually lose that person to suicide as a death. And untreated disorders can lead to more complications like substance disorder and things. So yeah, so I think Dr. Wilona, if you and I continue talking, we're going to go on for a lengthy period of time. And I know you have to get back to a busy life, and I have to get back to something that I pretend that I have a life. So I think, let's just kind of like wrap it up here today, and take it up next time with maybe a different topic. What do you think?
I think that's a good idea. Let's continue this.
So here's Sharing Shrinks signing off. Hope to see you guys next time.
See you guys.